presenting. So I just wanted to do a little introduction to say welcome to Dr. Anna and thank you for joining us tonight. She's going to give a talk on polycystic ovary syndrome and its associated symptoms, I think is the way I want to describe it. But obviously I'm not the expert, so I'm going to hand over to you and let you do that.
Thank you so much. Can I just check that everybody can see some slides on the screen just now and there's not anything else like popping up with anything else on it? Fantastic. It's been a long time since I was screen sharing on Zoom. But thank you very much for having me this evening, everybody. As Jo was saying, my name is Anna and I am a resident doctor working in obstetrics and gynecology in the west of Scotland. I'm currently working in Ayrshire and Arran. And I'm going to talk a little bit about just kind of the medical and scientific side behind endometriosis and PCOS. I'm going to kind of touch on both of those conditions. As I'm sure a lot of you are acutely aware, they can often come hand in hand, which is why I'm talking about the both of them. So as a quick overview of what I'm going to look at, because I want to also check those slides have definitely moved on to the next slide, haven't they? Fantastic. So I'm going to talk a little bit about definitions of endometriosis and PCOS, pathophysiology, which is the medical word for how do these conditions actually work as far as we understand it, a bit about some of the signs, symptoms and associations with these conditions, how we diagnose and manage them, and I'm going to touch briefly at the end on some of the sort of new research that's coming out in the area. So some disclaimers, as Jo was obviously mentioning before we started, I'm not yet a fully qualified specialist or expert. I'm not a consultant, but I am working in the field at the moment. And whilst I am a doctor, I'm not your doctor. So I can't really give any specific medical advice to anybody. But what I would say is that if anything that I'm talking about tonight is something that you're experiencing, that you're concerned about, please definitely go and speak to your own teams about it. And another sort of thing that I'm going to say is in terms of terminology, whilst I'm doing this talk, I might use terms like women or female. And I just think it's important to acknowledge that not everybody affected by these conditions will identify as a woman or as female. I think it's really important to be mindful of inclusivity in language, but sometimes I'll put a little asterisk beside women and things like that. And that's what I'm meaning when I'm saying that. Yeah, so I'm going to start off with the endo side of things and then move on to PCOS in the second half of the talk. So endometriosis, definition being the presence of endometrial-like tissue outside of the uterus, the endometrium being the tissue that lines the inside of the womb. It's the stuff that builds up throughout your menstrual cycle in preparation for possible implantation of a fertilized egg, and it will shed and cause your period if you do not become pregnant in that cycle. It's estimated to affect roughly 1 in 10 women during their reproductive years, which makes about 190 million people worldwide. And amongst the women diagnosed with endometriosis in adulthood, nearly a fifth of them will report that their symptoms began before the age of 20, and 2/3 of them will report onset before the age of 30. Exact time of disease onset is kind of unknown because the symptoms need to emerge and be considered sufficiently life-affecting to gain a referral for a definitive diagnosis, which is a process that often takes a very long time. And it's got a very widely varied presentation. Some people will have minimal to no symptoms, whereas some people will be completely debilitated by their symptoms. So it's a bit of a spectrum. This little graphic is from an article that the British Medical Journal published for clinicians to help kind of figure out ways that you can suspect a diagnosis of endometriosis in someone, some of the things that should be pointing you towards it. And I've mainly just included this to show the vast variation in different presentations of endometriosis. So patients can have a wide range of these symptoms, ones that seem completely unrelated to each other, or they might even have none of the above. So in terms of types, subclassifying endometriosis into its subtypes, the majority is what we call abdominal endometriosis contained within your abdomen and pelvis. Of the abdominal type, there's 3 main subtypes. The first type is superficial peritoneal. The peritoneum is this like large membrane covering all of the organs inside your abdomen and pelvis. And when we say superficial, we mean just on the surface of that. So that can kind of occur anywhere. Ovarian, so a lot of the time it will attach onto someone's ovaries, or deep endometriosis, which is sort of further into the tissues and can be a bit harder to detect. The remainder of patients with endometriosis will have what we call extra-abdominal, which is where it can move kind of anywhere in your body. I've heard cases of endometriosis being found like attached to people's bones, attached to people's lungs in some very rare cases as well. That's a very small percentage overall, the sort of 1% up to 12% at the most being extra-abdominal. And it can be iatrogenic, which I've put in inverted commas there. iatrogenic is a word which means caused by medical intervention. The reason that I've put it in inverted commas is because the most common site of this would be like caesarean section scar endometriosis. In this case, I mean iatrogenic in that you wouldn't have a caesarean scar unless we'd given you a caesarean section, not that doing the section has in any way caused the endometriosis to develop. It just kind of happens of its own accord. So this diagram here, again, comes from that same British Medical Journal article. It's explaining how we think endometriosis works. There's still an awful lot from the medical community that we don't know, and there's a lot of ongoing research into figuring out exactly what it is that goes on with endometriosis, but this is kind of our leading understanding of it at the moment. So up on the sort of top left-hand corner here, what this is demonstrating is what we think is what contributes to the pain that's most often associated with endometriosis. The womb lining tissue being where it shouldn't be causes sort of localized inflammation in the area that it's in. It causes the development of new blood vessels and new nerves where the new tissue is growing, and the sort of multitude of hormones are involved can increase the expression of nerve channels which are sensitive to pain signals, and therefore that increases the sensitivity to the pain signals in the area, and it can cause sort of changes in your peripheral and central nervous system, which results in something that we call central sensitization. And that is potentially an explanation why some people will have ongoing chronic pelvic pain even after all of their gynecological organs are taken away. If you go into hysterectomy, there's a small percentage of people that unfortunately continue to suffer pain because their body's been so used to getting pain signals from that area that it's hard for it to kind of switch that off. This kind of bit over here is explaining a little bit about how it's a mixed phenotype pain. So when we talk about chronic pain in medical services, there's a few different types of pain. There's kind of three major ones. Endometriosis pain, because it is caused by a couple of different pathways, it doesn't really fit neatly into any of those categories, so it can be quite challenging to treat because it can involve nervous system things, it can involve physical things like adhesions and the sort of pressure sensations. So that can be why the pain is quite notoriously tricky to treat for us. This little bit up here is talking a little bit about why we think some of the factors associated with endometriosis can cause infertility. Sort of just generalized inflammation in the area, adhesions perhaps causing distortion of the anatomy of pelvic organs, so things being sort of pulled over to one side where they're not supposed to be, tends to lead to decreased normal function of the ovaries with less eggs released, and therefore making achieving pregnancy more difficult. We also think that part of the reason is that the endometrium tissue that is in the correct place doesn't really function in the way that it should, because obviously some of it's not in the correct place, and therefore it's harder for it to support the implantation of an embryo and go on to achieve a successful pregnancy. So some of the signs, symptoms, and associations that you get with endometriosis, there's lots of fancy medical words coming up on your screen. These words in order, so chronic pain, cyclical and non-cyclical, you can kind of figure that out. Dysmenorrhea is the medical term for painful menstruation. Dyspareunia is pain on deep penetration during sex. Dyschezia and dysuria are pain passing stool or urine, and subfertility being less successful in achieving pregnancy. Comorbidity means to have more than one health condition at the same time, and this is something that we see with multiple conditions, but particularly with endometriosis. In patients with endo, we see a high rate of different chronic pain conditions, oftentimes with mental health conditions and other non-malignant gynecological issues like adenomyosis, uterine fibroids, polycystic ovarian syndrome. By non-malignant, we mean non-cancerous. We also note that there's a slightly higher risk of developing other conditions, such as subsequent malignancy, early menopause, autoimmune diseases, and certain vascular diseases, vascular being your blood vessel system. When I'm saying that, I'm not trying to scare anybody or imply that everybody with endometriosis is going to get one of these things. When we say higher risk, we mean relative to the normal population risk. And it's important to remember that the normal population risk of these things is generally low. So a slightly higher risk than a low risk is still a low risk, if that makes sense. So to diagnose endometriosis, this is a list of things from the NICE guidelines, which are given to clinicians in the NHS, advising when we should be suspecting a potential diagnosis of endometriosis. So if someone is coming into your, sort of whether you're a GP or a gynecologist or any other kind of professional, if someone's coming in with chronic pelvic pain, they're coming in with painful periods, which is bad enough to affect their activities of daily living or quality of life, if they're coming in with pain and deep penetration and sex, any kind of period-related or cyclical seeming symptoms with their gut, such as sort of irritable bowel type syndromes, or frequent UTIs around the time of their cycle, or if they are struggling to get pregnant in association with one or more of these things, then there's a potential that that person has undiagnosed endometriosis. It's important to ask about family history because we know that in first degree relatives, if they've got endometriosis, you've got a higher likelihood to have it yourself. We know that there's definitely some kind of genetic link going on, but we don't know exactly what it is yet, and we suspect that it's multiple different genes involved. We should do an abdominal and pelvic examination physically to identify any signs such as reduced movement of the organs or enlargement of the organs, any kind of tenderness or pain in parts where there shouldn't be, or any visible external lesions, because some people do manifest an endometriosis sort of within the vaginal canal itself, which is something we can see on examination. And just as a quick warning before I go on to my next slide, there's going to be some surgical images on that slide, so if you're squeamish about that sort of thing, maybe avert your eyes. So to diagnose endometriosis, transvaginal ultrasound scan is usually our first port of call. It's not a super pleasant examination to have done, as I'm sure anybody that's undergone it will be able to attest, but it gives us a much clearer view of the pelvic organs if you're able to tolerate that exam, because we can get the probe closer to where it needs to be. Some patients will go on to have an MRI scan. That's what you can see in this picture up here. And these red arrows are pointing to some endometriosis lesions on this patient, which are infiltrating into her rectum, which is quite hard to make out, but trust me on this, they are there. And these pictures down the bottom are from a diagnostic laparoscopy, which is keyhole surgery, so that we can go in and actually look at the organs and see what we can see. We call this the gold standard because it's the kind of only way that we can get a definitive diagnosis. So someone could have gone through all the kind of blood tests, hormonal tests, physical tests, ultrasound scans, MRI scans, and not see anything because the type that they have is not visible on those scans or those tests. So these two at the top here, and it looks like kind of tiny little black dots, these are some of the superficial peritoneal type of endometriosis. This one down on the bottom left, it's a sort of dark bubble looking thing. This is something that we call an endometrioma, which is a type of cyst from endometriosis, and it's basically old blood that's built up inside of that when it's been trying to shed its womb lining, but obviously it's not in the womb, so it's got nowhere to go. And on this side, you can see one of the endometriosis lesions that is currently bleeding a little bit, because these things can be very fragile in operations, and sometimes even if you just touch it with the tip of the instrument that you're using, they will bleed. Recent data that we've looked at from patient surveys and things like that does suggest that the average time from someone's initial presentation with endometriosis symptoms to healthcare up until their definitive diagnosis, currently sitting at about 8 years, 10 months. I'm sure, again, yourselves will be very familiar with the process. It's definitely making some progress from the previous 10 years, but as you can see, we've got a long ways to go. So classification of endometriosis, there's no kind of perfect system in use. There's a couple of different ones. This one in the picture is something called the Revised American Society for Reproductive Medicine's classification. I think it's the most common one used, which is why I've included that in the picture. You might hear people talking about having stage 1, 2, 3, or 4 endometriosis, and this is what they're referring to when they say that. This scale is based on what we can see during an operation, and it's good in some ways because it tells you like the extent that you can actually physically see, but it's got a pretty poor correlation with the levels of pain that somebody's in, with their prognosis and with their fertility outcomes. This one is a New Zealand-based one, the NZAN, or hashtag NZAN, I think is the updated one, which is better for classifying deeper endometriosis, but again, correlates quite poorly with your symptoms and your fertility outcomes. And then there's another classification system called the Endometriosis Fertility Index, which is quite helpful for predicting whether we'll be able to successfully achieve a pregnancy following any operative treatment, but not really good, again, for classifying how bad somebody's symptoms are. So different treatment options. We start off with analgesia, pain relief. There is something called the analgesic ladder, which has been published by the World Health Organization for all kinds of pain treatment, starting off with sort of your simple analgesia and then building up from there. As I was mentioning earlier, because it's a very mixed type of pain that you get with endometriosis, again, it can be quite hard to figure out the right combination of pain relief for somebody. Some things that will work really well for some patients, or for the majority of patients, will not work for others. So oftentimes things like non-steroidal anti-inflammatories, sort of ibuprofen type 1s, diclofenac, mefenamic acid, things like that, those work well in the majority of people, but for the people that it doesn't work well in, it can be a little bit trickier to figure out what the best options for them are. There's sort of medical and hormonal management. So the combined oral contraceptive pill is usually our first port of call for people that it's appropriate for. It's a pill that you can take back to try and prevent menstruation, to try and lessen some of those symptoms from that point of view. Progestogens are a synthetic type of progesterone hormone, such as Provera tablets. The aim of those is to shrink down the endometrial tissue and keep it thin. And again, you can use these to stop periods occasionally. GnRH analogues are usually injectable types, things like Decapeptyl. GnRH is the name of the hormone which causes the production of two hormones which control the menstrual cycle, follicle-stimulating hormone and luteinizing hormone. So if we give you these drugs, in time it will, in a negative feedback, inhibit the release of those two hormones, FSH and LH, and effectively switch off the menstrual cycle. So you might hear it described as sort of medically induced menopause, which is great for stopping your periods and the symptoms that come with it. The downside is it comes with the menopause and you get a lot of symptoms with that as well. So oftentimes if anyone's on this for a long time, they will add back HRT, usually in the form of a tablet called Tibolone, to try and downplay that side of things. We also try to avoid giving these on a super long-term basis. So I think you can use, I'm pretty sure it's licensed up to 2 years, although don't quote me on that at the moment. And the reason that we don't advocate it for many years at a time is because it increases your risk of osteoporosis very slightly. And women are higher risk for osteoporosis anyway, because estrogen is the hormone that's really important for bone protection in female patients. And natural menopause causes a drop in estrogen anyway, which can increase your risk. Obviously, if we are inducing your menopause earlier, you've got a longer time to not have estrogen in your system. And an IUS is an intrauterine system, such as a Mirena or Levocert coil. These are usually really good at making people's periods lighter, less painful, or stopping them altogether. And it's also a really effective form of contraception. So if that's something that you're looking for, then it's kind of a win-win. It also tends to avoid most of the hormonal side effects you get with stuff like the pill, because the hormones that need to be there are localized within your uterus rather than systemic all over your body, the way that it would be if you're taking it orally or with an injection. So that's usually a good option for people that respond well to hormonal treatment but can't manage with the side effects that you get with systemic hormone. Other kind of medical options include different options to try and stop bleeding, things like tranexamic acid. This is something that we use for control of bleeding generically, not just for gynecological related bleeding, but again, it's something that we usually only give in short bursts. And for some people, it will completely stop their bleeding. Some people, it will only just kind of lessen it to a point. And then we've got surgical management. So you can get laparoscopic excision or ablation. This is the keyhole surgery that I was telling you about. This picture shows a robotic assisted surgery, which is brilliant because it allows the surgeon really precise control of their instruments to a degree that you wouldn't be able to with traditional keyhole surgery. Usually associated with faster recovery and better outcomes for patients. I know that there's a surgeon at the hospital I work in that does same-day hysterectomies with a robot. Patients come in the morning and go home that evening, which would have been unheard of even 5 years ago, probably. The precise control that you get with the robot can sometimes allow your surgeons to remove more endometriosis tissue than in traditional laparoscopy, although sometimes it's unfortunately still not possible to remove all of the tissue safely without causing too much damage to surrounding organs or higher risk of bleeding, in which case sometimes we do have to leave some behind. And hysterectomy is usually the sort of final bastion of treatment for people. It doesn't always solve everybody's problems, as I've mentioned before, with the way that the pain pathways can be changed in your nervous system with endometriosis, but it is an option for some patients, and some will feel a really huge benefit from doing this. Generally, if you're going to do a hysterectomy, you'd want to take the ovaries away as well, because the ovaries are the primary hormone drivers and usually drive the issue. But this is something that you need to take a lot of time to consider in somebody young, because that will cause permanent surgical menopause and all of the issues that previously mentioned come with menopause, also as well as permanently impairing your fertility. Any surgery that we do also increases the likelihood of adhesions forming. Adhesions when tissues that aren't supposed to be sticking together kind of stick themselves together with scar tissue. And they can be a little bit of a vicious cycle of pain sometimes, because some people will have adhesions and not feel anything from it. Some people very much feel things from adhesions that they've got. And if you go in to do another surgery to divide up the adhesions, you're doing another operation, which increases the risk of more adhesions, and it kind of goes round in a circle like that. If you ever do end up considering or getting a hysterectomy, something important that your surgeon will likely discuss with you, but important to ask, is whether or not they've taken your cervix away too. That's what we call a total hysterectomy versus a subtotal hysterectomy. Sometimes some of the cervical tissue is left. The reason that you need to ask that is to figure out if you still need smear tests after your surgery, because we wouldn't want anyone to miss out on getting their smear test if they still need it. And this slide, which is kind of visually very boring, but it's a summary basically of all the guidance that we're given explaining the steps from suspected diagnosis of endometriosis to definitive treatment for clinicians. This is something, again, I've gotten this from the British Medical Journal again, but you can Google nice guidance endometriosis if you ever fancy having a look at it. It's full of medical jargon though, so it's maybe not as interesting to the general public as it is to me. I'm going to move on now to talk a little bit about polycystic ovarian syndrome. So it is a very common endocrine condition affecting an estimated 10 to 13% of women of reproductive age. And it's got three key characteristics: irregular periods due to irregular ovulation, excessive androgens, which is the raised male sex hormone levels, and polycystic ovaries. If you have 2 out of 3 of these features, it's considered diagnostic for PCOS. So what I mean by that is that you don't necessarily need to have visible cysts on your ovaries to be considered to have a diagnosis of polycystic ovarian syndrome. So you don't necessarily need an ultrasound or anything like that to confirm it. It is a disease that accounts for the vast majority of raised male sex hormone levels in females, but there's a lot of difference in what we call the phenotype between different countries, ethnic origins, different people. A phenotype is the sort of physical characteristics of someone that you might expect to have this disease, but obviously bodies haven't read the textbook, so it presents very differently in a lot of different people. We don't really know exactly what causes it yet. There does seem to be some kind of family history element, but again, we think it's probably multiple different genes and we don't know exactly which one yet. Of these 3 features that I mentioned, none of them are what we call pathognomonic for PCOS. That's a fancy term that means any kind of specific sign, symptom, or unique characteristic of a disease that you can definitely pin down on that condition. There's nothing like that for PCOS. It's something we call a diagnosis of exclusion, which I'll go on to explain a little bit in the next couple of slides. And these 3 criteria here are what we call the Rotterdam criteria, and these are our criteria for diagnosis. So again, this is another diagram attempting to explain how the disease actually works, but it's very small, very complicated, and also we don't really know exactly how it works. This is what we are suspecting goes on. We think there is a disruption of something called the hypothalamic pituitary gonadal axis, which is basically the hormone signaling pathway from one gland in your brain to a different gland in your brain to your ovaries. We think that there is an increased amount of this GnRH hormone, which increases the ones that control your menstrual cycle and end up causing your ovaries to overproduce male-based sex hormones, because everyone produces a little bit of male sex hormones, but there's a sort of lower level that you would expect in someone that's phenotypically female. So the signs, symptoms, and associations. Again, there's going to be lots of fancy medical words that will come up on your screen, and I will translate those into English. So anovulation means not ovulating. Oligoovulation means ovulating infrequently. And then amenorrhea is not having periods. Oligomenorrhea is having infrequent periods. Hyperandrogenism is raised levels of male sex hormone. Hirsutism is excessive hair growth, which is usually in a male pattern. Insulin resistance, which is why this is something that we often see in people with diabetes. Obesity, acne, scalp hair loss, again, sort of male pattern type hair loss. Strong risk factors that we've noticed are in somebody that has a family history of the condition. Premature adrenarche, and adrenarche is a specific part of the early onset of puberty. The part's driven by your adrenal glands, which are sitting on the top of your kidneys. So the signs are for adrenarche are things like developing underarm or pubic hair, starting to develop body odor, more greasy skin, not things like breast development or menstruation. Those are later stages. But if you were somebody that underwent the adrenarche part of puberty early, then you might be slightly higher risk of developing PCOS. And obesity, we know, is a strong risk factor for it as well. Other risk factors which are not as strong but are potentially contributing are things like having been born with a low birth weight, having had exposure to androgens while you were in the womb. So for example, if your mum had PCOS, she's got a higher level of androgen circulating, so you've had a bit more of it in the womb, or other kinds of environmental endocrine disruptors. And we have an increased risk of the following comorbidities, conditions along with it. Type 2 diabetes, hypertension means high blood pressure, high levels of blood cholesterol, cardiovascular disease in your heart or in your blood vessels, obstructive sleep apnea, fatty liver disease is what that I think is metabolic associated steatotic liver disease is what we call it now, but fatty liver is what it's more commonly known as. Overgrowth of endometrial tissue that's not normal or endometrial cancer, anxiety and depression, and very often disordered eating or a negative body image, which is usually a kind of secondary thing to some of the symptoms that you can get in terms of struggling with acne, struggling with your weight, struggling with excessive hair growth in places that you might not want it. So this is a little slide just with a subtle distinction between polycystic ovarian syndrome and polycystic ovarian disease. They're not exactly the same thing, although there's a lot of overlap. Polycystic ovarian disease is where your ovaries are producing lots of immature or partly matured eggs, which then go on to develop into cysts rather than full eggs. It causes your ovaries to be enlarged. The larger your ovaries, the more androgens they will produce. Generally, the disease has got slightly milder symptoms and a slightly milder impact on your fertility. If you have the syndrome, then it's a more complex hormonal and metabolic condition that's got more basis in the full body hormone system rather than just within your ovaries. So there's no formal classification system in place for PCOS, but there's a couple that have been suggested. This is one that the British Medical Journal has potentially suggested. The first category that they've got is mild PCOS. A patient falling into this category would have irregular periods and evidence of polycystic ovaries on ultrasound, a mildly raised level of androgens in their blood, but normal insulin concentrations. That's suspected to make up about 16% of people with the syndrome. Ovulatory kinds, people would tend to have normal periods. They would have evidence of polycystic ovaries on ultrasound, raised androgen levels, and raised insulin concentrations, and that's another 16%. Hyperandrogenism and anovulatory would have irregular periods, but their ovaries appear to be normal on ultrasound, raised levels of androgens, and raised insulin concentrations. And the severe kind, you've got the whole lot. You've got the irregular periods, you've got the polycystic ovaries evidence on scan, you've got your raised androgens and your increased insulin concentrations. And that actually makes up the vast majority in this proposed classification system. So diagnosis, there's a lot of different things that your doctor might suggest if they suspect PCOS. A physical examination is one. It's sort of the baseline of everything that we do in medicine, and you might be able to see some of those signs, like, for example, excessive hair growth on a physical examination. Blood tests, this is a whole panel of blood tests that might be suggested if your doctor is suspecting PCOS. The hormonal element to this, so you've got androgen profile, timed LH, FSH, and progesterone. The timing of your hormonal blood test to the dates of your cycle is quite important because of the nature of female hormones being released on a cyclical basis, as opposed to male hormones, which are just kind of at a set level all of the time. These other blood tests that I've mentioned here are basically wanting to rule out anything else which could be contributing to your symptoms. So TFTs are thyroid function tests. If you've got an underactive thyroid, that can reduce the frequency of your periods. Prolactin is the breastfeeding hormone, which can be secreted, obviously, if you're somebody that's breastfeeding, but also if you have a certain type of brain tumour which secretes prolactin. So it's important that we rule out anything else that could be contributing it before we pin it all onto PCOS. OGTT is an oral glucose tolerance test, which you might do if you're suspecting the insulin resistance side of thing in somebody. And a pelvic ultrasound. You get this, what we call a classical string of pearls appearance, which I'll try to explain. So on this left-hand side, this is what a normal ovary looks like on ultrasound. You can see this one big black dot in the middle. This is a dominant follicle, which is going to be the one that goes on to ovulate and release the egg in that person's cycle. This one here is a polycystic ovary, and you can see we've got black circles, but we've got tons of them, and none of them are dominant the way this one is. There's not one big black circle. There's lots of them of a kind of equal size, and it kind of looks a little bit, if you squint and think about it, like it could be a string of pearls, which is why we refer to it as that. Not all people with PCOS are actually going to have this appearance on ultrasound, as we said, so it's not an absolute requirement to have a scan to be diagnosed with it. And as I've mentioned, it's a diagnosis of exclusion. And what I mean by that is that we will look for other causes first, and if we can't find one, only then will we attribute your symptoms to polycystic ovarian syndrome. The reason for that being, obviously, we've got no definitive test that we can do to pin it down to that, and we wouldn't want to miss anything else that would be perhaps more easily treatable or perhaps more serious by just sort of explaining everything away as though it's PCOS. So treatment options, one of the mainstays is lifestyle change, because a lot of the factors that are causing symptoms in PCOS are because of the insulin resistance that tends to come with people that struggle with their weight with it. And I completely understand and appreciate that it can be really frustrating to hear from medical professionals that losing weight will help your issues. it's important to understand that it's not meant to be a dismissive, like, oh, your problems are just because you're fat or something like that. And I know that it can definitely come across like that from some people. In this case, it's genuinely backed by the science behind the condition, because we know a lot of it is driven by this insulin resistance, which is something that we know is increased in people that have got a larger body mass. It's a very easy thing for somebody to say, and it's a very, very tricky thing for somebody to actually do. I realised that my slides have not changed over. There we go. Fantastic. Things such as Manjaro, for example, are very, very new on the scene, and it's something that a lot of people see a lot of success from. It's important that you do your research before taking anything like that. Make sure you use trusted sources, and please tell your doctor if you are taking it, because we do need to know all the medications that somebody is on. Obviously, also this part of advice that we would give only applies to people that we would medically classify as overweight, because not everybody with PCOS is, and it's not going to be something that will help you if you are not. Smoking cessation, stopping smoking is great advice for everybody, no matter what is wrong with you or not wrong with you. I would always advise stopping smoking and vaping if you can. If you are somebody struggling with subfertility secondary to polycystic ovarian syndrome, so if you're trying to get pregnant and you're not managing it because you've got PCOS symptoms, and you're somebody that's overweight, if you will likely go on to need IVF to conceive, then there's really, really strict health criteria on the NHS, including things like your BMI, your smoking status, recreational drugs, and things like that. Something I would say is definitely worth doing if you think that that is potentially you and something that you're going to be pursuing in the near future. Worth looking up your local health board's criteria and figuring out what they are, and working towards achieving those criteria for yourself very early in your fertility journey, so that if you do get to the point where we've been through rounds of fertility treatment and you do need to go on to IVF, you're not going to add any further waiting time by having to wait until you've got your BMI below a certain level or until you've stopped smoking or whatever. If you can invest in yourself from that point of view early, it will speed things up for you later down the line. In terms of management of symptoms, if you are wanting to just regulate your cycles, but you're not somebody that's wanting to achieve pregnancy at the moment, things like the combined oral contraceptive pill, hormonal intrauterine system like a Mirena, or progesterone tablets, again, kind of all the things that I was saying in terms of endometriosis would apply in this case. Or if you're trying to manage your associated symptoms, if you are somebody, for example, that's really, really struggling with acne, then you can get topical antibiotics or oral antibiotics to try and treat that, or even onto retinoid treatment under the advice of a dermatology specialist. Or things like a fluorinethine cream or any kind of anti-androgens for reducing male pattern hair growth if that's your major symptom. Fertility-wise, there's a couple of different options here. Clomiphene, or Clomid as it's more commonly known, and letrozole. These are ovulation inducers, because usually that's what's causing the difficulty in conceiving for PCOS patients, is because you don't ovulate on a predictable regular cycle the way somebody that doesn't have the condition would. Letrozole is a drug that we've used for many years as a breast cancer treatment, but it's quite new on the scene for fertility purposes. Does seem to be having good results so far, particularly in that it reduces the risk of superovulation that you can get with Clomid. You often hear of twin, triplet, or more pregnancies produced on Clomid because it causes a lot of eggs to be released at once. Metformin is a diabetes drug, so its use in PCOS is called off-label because it wasn't originally designed for the treatment of PCOS. But we've noticed that in patients with insulin resistance, it really gives good results and oftentimes is good in achieving a successful pregnancy. And IVF, as I was mentioning, obviously is an option if all the other fertility treatments don't seem to be working well for you. So another option that I've included there, a surgical option called laparoscopic ovarian drilling. And what it does is keyhole surgery to basically take away some of the ovarian tissue, the androgen-producing tissue on the outside of the ovaries, shrink them down a little bit, and aims to restore normal ovulation. And it has actually got quite a high success rate for patients in that case. So looking a little bit onto the future, I'm going to briefly touch on some of the research in the area. Women's health in general has been a historically under-researched area, so it's great that we're finally starting to see a bit of a change in that. There are a lot of new drugs that are coming out, like Ryco tablets, which are showing really good promise for treatment of endometriosis symptoms. It's a once-a-day tablet, and again, it tends to kind of medically induce your menopause. It's not currently an option for people that are trying to conceive, unfortunately, because of the way that it works. But this is something which is licensed to be taken on a long-term basis, unlike your injectables like Decapeptyl, which is great. It's important to still watch out for your bones if you're on any kind of hormonal treatment if you're a woman. We're looking at new methods of diagnosing as well. We're looking for things in the biomarkers, things in the genetics, because again, we figured out that there's some kind of genetic component. We just don't know exactly what it is yet. So there's a lot of research into that to try and make diagnosis quicker and faster and cheaper for people. and advanced imaging techniques. So MRI is something that's becoming more and more specialised. Different kinds of medication, things like the aromatase inhibitors, things like letrozole and things like that will help to try and control your estrogen and progesterone levels. Personalised medicine is something that we're looking at in a lot of conditions in general, but especially for endometriosis, again, trying to tailor things to an individual person in terms of their genetics. If we can find the genetic links for it, then that's something that's opened up in the future. And robotic surgery, as I was kind of waxing lyrical about earlier, I think robotic surgery is really cool. And it's associated with really good outcomes for patients. And again, the thought of going home the day that you've had a hysterectomy is something that you would have got laughed out of the hospital for several years ago. So it's amazing that that's now a reality that we're seeing for people. And in the PCOS side of things, a lot of the research, again, is based on the inheritability side of things. We're looking at the genomic studies and the family history links that we're getting. We're still trying to figure out exactly what causes the condition. So the more that we can find out about how it's passed on, maybe the more we can find out about how it works. Management of it, I've kind of listed a bunch of different names of medications there. All of these treatments are basically attempting to restore the natural ovulation of a cycle without PCOS. These things, the in vitro gonadotrophins as well, are part of fertility techniques, trying to increase the likelihood of achieving a successful pregnancy. And I mentioned there as well repurposed anti-diabetic drugs. Obviously, we have metformin, but things like GLP-1 agonists and various other kind of drugs are in process because, again, a lot of people have the insulin resistance side of things, and that's actually the main driver of the symptoms that they're experiencing. So the more that we can do to try and combat that, the better. And I've spoken at 1,000 miles an hour, and I hope that any of that made sense. I'm happy to try and answer any questions to the best of my ability. But thank you guys so much for having me this evening.